Thank you, everybody, and welcome to our webinar. We understand that this is a very difficult and very confusing time for everybody, and that everybody is very preoccupied with their own safety, their families, and looking after all of our patients with heart disease and stroke. So thank you to everybody who's joined us today and who's taken a few minutes out of their day to be with us. We're here to present to you our new guideline, which was published yesterday, about the use of ASA for primary prevention. This is a very unique guideline in that it was a cooperation and collaboration of many heart and stroke related organizations across country, and it was a wonderful coming together and coming to consensus on these. So rest assured that these are very credible because there's been this tremendous outpouring from everyone. As you see from our speakers today, we have three very prominent speakers joining us to talk about this. So Dr. Ted Wein from Montreal, who's a neurologist, he has led this whole charge. He's been the chair of our writing group. Christine Papoushek, who's a pharmacist and a doctor of pharmacy, who's been instrumental in bringing that perspective for us. And Jeff Habert, who's a family physician and involved in Thrombosis Canada, who's been excellent at bringing that other perspective. So together, neurology, cardiology, pharmacy, family docs are really at the front line dealing with the public and with patients every day about this issue. So hopefully today they will share their wisdom with you and be able to give you guidance as you work with your patients on understanding what this is all about. So thank you again and welcome. And again, please send us your questions. We'll do our best to answer as many as we can at the end of the webinar. And I will now turn it over to Dr. Ted Wein to do his presentation.
Thank you very much, Patty. And thank you all for taking the time to, out of your busy schedules. I know that there's a lot of questions out there with our current pandemic on various issues related to cardiovascular disease and the question of use of NSAIDs and COVID, as well as the use of ARBs and ACE inhibitors. We still do not have enough information on any of these subjects, which we're all interested in, and have to wait till additional information will come out. And despite the COVID crisis, there are still people having heart attacks, strokes, and suffering from peripheral vascular events that still need to be addressed. And that's why I think it's really important to go ahead with this webinar today to focus on the benefit of aspirin in primary prevention. What led our group to begin this venture was really three major trials that were published in 2018, the Aspirin trial, the Arrive trial, as well as the Ascend trial. All three trials showed that there was no benefit in reducing vascular events for the most part, but that bleeding risks were significantly increased, negating any benefit from this. And it was these three trials that really spearheaded us to relook at the data to find out what would be the best practice recommendation for Canadians. This was spearheaded by Patrice Lindsay at the Heart and Stroke Foundation, and thank you to her for putting her team together to do an extensive review of the literature. And our new recommendations were just released yesterday in the CMAJ. What I hope to do in the next several minutes is to really go over the highlights of each of these trials in order for you to better understand how we arrived at our conclusions and our guidelines. Prior to this, the Heart and Stroke had done a survey of the Canadian population just several weeks ago, looking at how many Canadians are actually taking aspirin. And if you look at it, we see that 5 million Canadians are advised by their healthcare professionals to take aspirin on a regular basis. Only 2.9 million actually follow their healthcare practitioner's advice, so 40% not listening to what their family doctor says, but almost another 2.5 million people are taking aspirin on their own. So this guideline really has an impact on 5.3 million Canadians who are currently taking aspirin, and the question is, should they be on it or should they not? The new recommendations have two parts to it. One is, please don't forget secondary prevention, that aspirin is strongly recommended for secondary prevention in individuals with symptomatic cardiovascular, cerebrovascular, or peripheral artery disease. I think the new recommendation is focusing on primary prevention. That is, the use of aspirin is not recommended for primary prevention of a first vascular event, level evidence A. This recommendation pertains to individuals with vascular risk factors who have not, I repeat, who have not had a vascular event, and for healthy older individuals without vascular risk. The net benefit of aspirin in individuals with asymptomatic atherosclerosis, however, is uncertain, and we can talk a little bit about that at the end. We also have a section on shared decision-making, that healthcare professionals such as physicians, primary care physicians, nurses, nurse practitioners, pharmacists, and physician assistants should really engage patients in an active dialogue, as well as caregivers, in discussion regarding the use of aspirin for primary prevention for vascular disease. And an individual's risk-benefit value should always be weighed, and preferences should be considered in order to make an informed decision to initiate continued or discontinuation of aspirin for primary prevention or vascular disease. The history of salicylates go back to ancient times. In fact, the willow bark has been reported to be used for medicinal purposes in the clay tablets from Mesopotamia in Iraq, and also on papyrus papers found in Egypt. Hippocrates referred to the use of salicylic acid tea to help reduce fevers in 400 BC. And then we have a hiatus until the mid-18th century when the willow bark extract became more recognized for its fever and pain and inflammation. Notice no mention of coronary artery disease there. In 1853, a French chemist, Charles Frédéric Gerhardt, treated sodium salicylate with acetyl chloride to produce acetylsalicylic acid for the first time. If you look at these two ads from in the 1920s, Bayer, just one of the many companies that make acetylsalicylic acid. If you look on the bottom, they stressed at that time in the 1920s that this product does not affect the heart. And in fact, they said it should be used for cold, pain, headache, toothache, etc. So even back then, there was a question of, is there an impact here? And maybe people should go with their initial gut feeling. Why are we going through this? Well, with medicine, things change with time, and we always have new data coming in. If you look at this ad from Bayer in the 1920s as well, the treatments that they produced at the time were both aspirin and heroin. And I'd like to point out that we no longer prescribe heroin for cough, and that we're always changing in our thought process as we treat our patients, with new knowledge being gained and decisions being made that need to lead to change within the community. So aspirin is one of the most widely used medications in the world. Over 40,000 tons of it are produced a year. That's 50 to 120 billion pills, but it is listed on the World Health Organization's list of essential medicines. So let us look at the 3 trials and subsequent 3 meta-analyses that led us to our decisions. The first one is the ARRIVE trial. The ARRIVE trial looked at men greater than 55 and women greater than 60. Men had to have at least 2 to 4 risk factors, including diabetes, including smoking, dyslipidemia, hypertension, and a positive family history, whereas women had to have 3 or more risk factors of smoking, dyslipidemia, hypertension, as well as a positive family history. These individuals had no history of vascular events, and they were randomized to receive aspirin 100 milligrams a day or placebo. The primary outcome was the composite point of vascular events of cardiovascular death, MI, unstable angina, stroke, and TIA. They had 12,500 patients with a mean age of 64 that were enrolled in this trial, and they had a mean follow-up of around 5.1 years. There was no reduction in the primary outcome or component. And if anything, the only thing they did find that there was a twofold risk in GI bleed rates. The absolute rates are listed below of 0.97% versus 0.46%. To put that in graphic form, you can see the primary outcome, cardiovascular, stroke, MI, cardiovascular death, with no significant difference between the blue and red lines here. We do see, however, on the bottom right, that GI bleeding was increased in that population. Although the absolute numbers are small, it clearly was the only increased risk factor that was doubled in this study. The second study was the Aspirin trial, also published in the New England Journal in 2018. Let's go through the details of this study. It included African American or Hispanic men or women over age 64 years of age, Caucasian men or women over 69 years of age. They had to have, again, no history of any vascular events, so an asymptomatic population randomized to aspirin 100 milligrams or placebo. The primary outpoint was the composite vascular endpoint, this time of major hemorrhage and cardiovascular disease, defined as fatal coronary heart disease, non-fatal MI, fatal or non-fatal stroke, or hospitalization for heart failure. They had almost 20,000 patients in the study with a mean age of 74 years of age, so an older population. After almost 5 years, again, there was no benefit in the primary outcome of a composite vascular event. What they did show, however, that there was an increased risk of hemorrhagic events in the aspirin group, a 38% increase, a p-value of 0.001. And the absolute values, again, are small, but clearly this clearly outweighed the benefit because there absolutely was no benefit in this trial. The third study that led us to form our conclusion was the ASCEND trial. looking at individuals in a diabetic population. In this study, men and women over the age of 39 with type 1 or type 2 diabetes with no history of vascular events were randomized to aspirin 100 milligrams or placebo. The primary outcome in this study was the composite vascular event of MI, stroke or TIA, death from any vascular cause, excluding and confirmed intracranial hemorrhage. They had over 15,000 patients with a mean age of 63, and they followed these patients for a good 7.5 years, so a much longer outcome than the other studies, follow-up than the other studies. In this study, they did show a 12% reduction in the primary outcome of composite vascular event. However, the risk of major bleed was increased by 30%. If you look here, you can clearly see the first vascular event. You can see a slight decrease of 12% in the aspirin group versus the placebo as shown in red. What's interesting is if you look at the time delay to this event, you can see that the benefit of the aspirin was seen in the first 3 years of treatment, but after year 3, you can see that the confidence intervals cross 1.0. However, in the analysis of all groups put together, we see the 12% reduction, however, not seen after the 3-year mark. The conclusions of the authors in the study were that aspirin use prevented serious vascular events in persons who had diabetes and had no evident cardiovascular disease at trial entry, but it also caused major bleeds. The absolute benefits were largely counterbalanced by the bleeding hazard. So the bleeding risk completely outweighed any small benefit that we saw in this study. So those were the 3 trials that led us to form our conclusion, but there's 3 other trials that were meta-analyses looking at various aspects of the data on aspirin use that I think are essential to look at. The first study was published in JAMA Neurology by Wein Wang, looking at frequency of intracranial hemorrhage with low-dose aspirin in individuals without symptomatic cardiovascular disease. They looked at 13 randomized controlled trials of 135,000 people, primary prevention population age 43 to 74, and the primary outcome was intracerebral hemorrhage. They found that low-dose aspirin compared with control was associated with an increased risk of any intracranial bleeding. In fact, the bleeding risk was 37% higher, or 2 additional intracranial hemorrhages for every 1,000 people treated. The greatest relative risk was predominantly for subdural and extradural hemorrhages, with a 53% increase in those types of cranial bleeding. If you look over here, you can see in group A with any intracranial hemorrhage, which where we see the 37% increase in bleeding. If you look at intracerebral hemorrhage, it just misses the confidence interval of being positive for increased risk with a confidence interval at 0.98, but at 23%, almost statistical increase in intracerebral hemorrhages. If you look at subdural or extradural, we see that 53% increase in intracerebral hemorrhage and no increase in subarachnoid hemorrhage. There was some subgroup analysis here that I just wanted to note. It looked like in Asians that there was 84% increased risk in intracerebral hemorrhage in this group, a population at much higher risk for this given the high prevalence there. So at least a race difference that should be distinguished from some other populations. And I'd also like to point out here in the red box that a low BMI, less than 25, was also another predictor of it who was at higher risk. Again, these are subgroup analyses only. The author's conclusion were that use of low-dose aspirin for primary prevention of cardiovascular events in individuals with symptomatic cardiovascular disease was associated with an increased risk of overall intracranial hemorrhage. The risk of intracerebral hemorrhage was particularly elevated in Asians, as well as those with low BMIs. And because the benefits of low-dose aspirin for primary prevention of cardiovascular events are really not well established now, the outcomes of increased intracranial hemorrhage are often catastrophic. These findings suggest caution when using low-dose aspirin in individuals without any history of symptomatic cardiovascular disease. The second study is a meta-analysis done by Mood and colleagues looking at the efficacy of aspirin for primary prevention of cardiovascular events. And they did a meta-analysis comprising of 11 randomized controlled trials with 157,000 people with known atherosclerotic disease. The primary efficacy was all-cause mortality, but the primary outcome was major bleeding. And they followed up these people for 6.5 years. The conclusion was that aspirin was not associated with a lower incidence of mortality, so no benefit for mortality. Aspirin was associated with a 47% increase in major bleeding. And aspirin was associated with an increased incidence of intracranial hemorrhage of 33% as well. As you can see here, I'm sorry it's a little bit off. It's just to look at the trends for all of these studies, really showing no benefit for all-cause mortality, but on the bottom seeing an increased risk of major bleeds. If we look at the diabetic population, a population that for years has taken aspirin for primary prevention, they showed absolutely no benefit in that analysis as well. We did see a slight benefit of 18% improvement in myocardial infarction, but this was completely offset by a 47% increase in major bleeding and a 33% increase in intracranial hemorrhage. Conclusions by the authors was that aspirin use among healthy individuals without known atherosclerosis appears to be associated with increased harm and lack of mortality benefit. In this setting, aspirin is possibly associated with a modest reduction in MI. However, this comes at a cost of increased bleeding, including intracerebral hemorrhage and intracranial hemorrhage. And their conclusion was that the routine use of aspirin for primary prevention needs to be reconsidered. The last trial is by Zhang and colleagues looking at the association of aspirin use for primary prevention with cardiovascular events and bleeding events. And in their review of 13 randomized controlled trials of 164,000 patients, and they have over 1 million participant years with almost 20% of the patients being diabetic, the primary cardiovascular outcome was a composite cardiovascular mortality, non-fatal MI, and non-fatal stroke. Their results were as follows. Aspirin use was associated with significant reductions in the composite cardiovascular outcome compared with no aspirin. So they did see a slight benefit, 11% reduction in subsequent cardiovascular events, number needed to treat 241. However, aspirin use was associated with an increased risk of major bleeding compared with no aspirin, and that was a 43% increase, number needed to harm 210. So here they clearly demonstrate, based on their NNTs as well as the absolute values presented to you, that the bleeding risk completely negated the small benefit we saw in this meta-analysis. If we look at the number of MIs needed to be treated, it's 361. Number of ischemic strokes for primary prevention needed to be treated was 540. Remember, the number needed to harm is 210. And if you look below in the second part of the graph, where we look at the increased bleeding rates of major bleeding, intracranial bleeding, and major GI bleeding, they all completely negate the benefits seen in all of the trials. The author's conclusion, the use of aspirin in individuals without cardiovascular disease was associated with a lower risk of cardiovascular events. However, it was offset by an increased risk of major bleeding. Their conclusion, this information may inform discussions with patients about aspirin for primary prevention of cardiovascular events and bleeding. So, primum non nocere. The first thing we learn in medical school is do no harm. And that is really something that we need to address. These studies have not addressed all populations out there. Those who fall through the cracks are race and gender, body weight, people with atrial fibrillation, hypertension alone, what to do with individuals, for example, who have small vessel disease on CT scan or MRI but have never had a stroke. What should we do for them? What do we do for the asymptomatic carotid atherosclerosis, which is still an area of contention? And these are studies that will need to be addressed in the future. Thank you.
Thank you very much for that excellent presentation, Dr. Wein. We greatly appreciate it. The last slide indicated all of the groups that have endorsed these guidelines. And as I said earlier, working together has really helped to move these forward and for there to be a lot of confidence on being able to endorse and support these recommendations in clinical practice. We're now going to move into another important aspect of patient care, which is the role of the pharmacist. And they are the front line for many of the public who will purchase aspirin over the counter. Here to present today is Dr. Christine Papoushek. Christine, over to you.
Great, thank you, Patty, I appreciate it. Thank you, Dr. Wein, for giving us a very extensive review of the evidence. I'm just trying to move my slides forward. Here we go, let's try this. Sorry. Patty, maybe you could take over the slides for me. Would that be okay? Because for some reason it's not working. Oh, there we go. There we go. Great. Okay. So again, thank you very much. I'm very happy to be here today to share my perspective and the perspective of our profession, how we can actually help move this evidence forward and to help our patients. Patty, I think I'm gonna need you to move my slides. Okay, so this slide here really just depicts in general the role of a pharmacist. So just a general overview of how pharmacists are quite actively involved in care of patients, whether they work in community or in the hospital or in a family health team. We are actively involved in collaborating with physicians and primarily providing direct patient care. It gives a good depiction of how we can do this through patient education, managing medication, looking at the patient, the big picture of all the patient's medications prescribed by all their different providers. We have the knowledge and ability to discuss and measure and manage cardiovascular risk factors, and as I mentioned, collaborate with other healthcare professionals. We're in a unique position, especially when it comes to cardiovascular disease, to actually have conversations not only with family doctors, but with cardiologists, neurologists, all various specialists, to actually ensure that we optimize the patient's medication regime to reduce any risk and to optimize and improve their outcomes. Next slide, Patty. So the advantage, as I mentioned, we have multiple advantages. As Patty mentioned, we are the first point of contact for those that are working in community pharmacies. Patients often will come up to the community pharmacist to ask questions. So ensuring that our pharmacist colleagues that are in the community are educated on these new guidelines is going to be critical and important to provide appropriate education to these patients and help them make appropriate decisions, and again, communicating with their doctors. As a pharmacist, whether you're in community or hospital or a family health team, we're the ones that are aware of all the medications that the patient's taking from all the different providers. I'm fortunate I work in a family doctor's office. Part of my role is really to optimize that medication list and medication management for the family doc, because unfortunately we don't always know. The family doctor doesn't always have that full list in front of them. So we do facilitate the coordination of care, often communicating quite frequently with the specialists in the care and making recommendations and collaborating with the specialists and providing that information back to the family doctor. And as it's been depicted that pharmacists are the medication experts, we've studied this for as long as physicians have gone to medical school, doctors of pharmacy, we have extensive clinical training. We are the ones that know the appropriateness of these different medications, the risks that can be associated with these medications, and how they can be optimal or detrimental based on comorbidities. We have the advantage to provide, because we get to know our patients just as well as a nurse or a physician or PA or NP, we have the ability to tailor the education about the medications to our patients and provide collaborative disease management in the context of all the various illnesses that they have, and in context of all the different medications and their concerns. We provide medication reviews and drug safety management, monitoring reconciliation. So whether you're in the community or in a family health team or in a hospital, pharmacists are critical and get involved with monitoring of the positives and the negatives with respect to medications and with respect to establishing what patients can expect. How do they know the drug is working? How do they know it's not working? How do they know it's causing harm? We're able to do that in conjunction with the patient, and then furthermore, share that information in collaboration with their primary care provider. And in the context of what we're talking about today, we have the ability to detect and control specific cardiovascular risk factors and their outcomes. And as I mentioned, collaborating with the primary care and the specialists. So I think I've said this enough, but with respect to the context of what we're talking about today, with aspirin and primary prevention, I think we have a huge role to play. And I encourage the other healthcare providers on this webinar to really capitalize on the use of your pharmacist, the role of the pharmacist. Because we're an educator to patients and providers, we have the ability to take this evidence, understand it, and then help distill it to the providers and to the patients. One of the things that are mentioned in the guidelines, which I think is imperative and something that we do quite often in the family health team as pharmacists and pharmacists in the community is the idea of shared decision making. I cannot stress this enough, how important this is going to be with respect to the new evidence that has been published yesterday. The dialogue with your patient is extremely important. We need to really understand the patient's values, preferences, their fears, their goals, and really help them to make a decision on whether or not they want to continue taking aspirin or not. This evidence that has been published is, it's unprecedented, and it is going to have a huge shift in what people are thinking and how people are going to move forward. So it's really important for us to have these conversations. Pharmacists have these conversations with patients, the other healthcare providers, as long as this is why we're doing the webinar today, so that you're familiar with the evidence and you can work together with the patient to have these conversations. Next slide, please. As Patty, one of the slides previously just showed all the endorsements, and I'm happy to see that both our national bodies, Canadian Pharmacists Association, the Canadian Society of Hospital Pharmacists, have endorsed these guidelines and are actually working together with Heart and Stroke and individually to disseminate these to my colleagues in the community and in hospital, so that we can be informed and we can actually move forward and have these conversations with our patients. The Canadian Pharmacists Association, they had a webinar-based strategy in December of 2020, their annual meeting coming up in the spring, and there was a recent Canadian Pharmacist Journal publication, which I will refer to, a algorithm written by my colleagues that was just published this month as well, basically addressing the primary care prevention issue and how individuals, pharmacists can have these discussions with patients. And I'll refer to an algorithm shortly, which is a tool. As for the Canadian Society of Hospital Pharmacists, they had a lecture or a session at the annual professional practice conference, and are working on various knowledge translation initiatives so that the pharmacists can actually be informed for this. Thank you. Next slide. So can you link on to this for me? This is just tools for practice, and for the family docs out there and nurse practitioners, nurses, pharmacists, and PAs, this is from our Alberta colleagues, and this was done, I think it was published last year, but it's just for anything with respect to wanting to get the distillation of evidence. This was done last year. As I mentioned, Tools for Practice is an excellent resource for all the things that are coming down for anything really with respect to primary care. But I just wanted to provide this as an example of how this evidence has been distilled, not only with this webinar, but if you need a one-pager, this is excellent, an excellent one-pager to distill the evidence that we're speaking about today. Okay, thank you. Next slide. So this is the algorithm that I was referring to that was just recently published in the Canadian Pharmacist Journal from my colleagues, Arden Berry and Bill Semchuk. They have given me permission to post this, but this is for my pharmacist colleagues, but can be utilized by any healthcare provider that are having these conversations with patients. It basically provides kind of a very straightforward algorithm in terms of how to move forward on whether we should be using aspirin or having these conversations with our patients, whether we should be using aspirin as primary prevention. Next slide. And again, it's the last resource, but again, just another resource to, and because some individuals, some patients actually respond better to pictures as opposed to words. So this is another example of a resource that you can use with your patient to have this conversation. Next slide. So just to summarize, I can't stress enough the engage, really have these conversations with your colleagues and most importantly with your patients. We really have to, this is going to be very confusing for many individuals. I mean, they may look at this like, oh, well, I can drink coffee, I can't drink coffee, I can take aspirin, I can't take aspirin. I think this is more important than the coffee issue. I think it's really important that we have these conversations with patients, really have an appreciation for their values, their preferences, and have them make an informed decision. I can't stress enough, please, for the healthcare providers out here other than pharmacists, please engage with your pharmacists. Reach out and see who's willing to have these conversations with you and to help optimize the medication management of your patients and their outcomes. Utilize the resources that I provided to help with these conversations. Be prepared for these conversations by reviewing the evidence summaries. Understand what this evidence means. Dr. Wein did a great job highlighting this, but really take a moment, look at the other stuff that's out there and really have an appreciation for what this means moving forward. As I mentioned, understanding the values and preferences of your patient will really strongly help you in these conversations. Collaborating with other team members and share the responsibility, look to see who's next to you, maybe not right next to you in the context of what's going on right now, but really have these conversations virtually and in your clinic and with your team, with your members of your team outside of your clinic. And respect the decisions and opinions of your patients and your colleagues. So, you know, everyone does things for reasons, and it's based on their own values and preferences. So it may not be what we may choose to do, but it's what they want to do. So we really have to be respectful and understand people come to decisions for reasons. And I think it's really important when it comes to medication management that we take it upon ourselves to give these patients all the information that they can possibly utilize to make the most appropriate decision for them. So thank you very much. I think that's my last slide.
That was amazing. Fabulous presentation. We'll now turn it over to Dr. Jeffrey Habert. Jeffrey is a family physician and really brings a whole different perspective, but is front line in terms of medication management with his patients. So Jeff, over to you. I am giving you control, and if you just click on your screen.
Yep, got it.
All yours.
All right. Thank you very, very much. And thank you to Ted for a great overview. And Christine, thank you very much. And I really cannot underscore enough how important the pharmacist is as a family doctor, especially in this regard. And you'll see as I go through it. But I think the partnership of family physicians and pharmacists will be very, very, very significant in this regard with our new guidelines. So these are my disclosures. I do a lot of education in the areas of diabetes, thrombosis, and mental health. So let's talk about the burden of CV disease. We certainly know it's one of the big four in primary care. I mean, we have cardiovascular disease, we have hypertension, we have diabetes, we have mental health, and these numbers are astonishing. I mean, we're looking at 18 million cardiovascular deaths in 2015 across the world. We know that it's responsible for 1/3 of all deaths in people over the age of 35, even more if you're older. We know that disease breeds disease, and we know that coronary disease and peripheral arterial disease are very strong predictors of future cardiovascular events. 90% of Canadians have at least one risk factor, and almost half actually have 3 or more risk factors for heart disease. In Canada, every 7 minutes, someone dies from heart disease or stroke. And I think what Ted said is so true. We're in a crisis now with this pandemic, but we can't forget what's really always been important to us. And this pandemic will go away, but we still need to keep dealing with our patients that are at risk for cardiovascular disease. And last but not least, and I think probably one of the most important things, is that stroke is the leading cause of adult disability in Canada and the 3rd leading cause of death. And we know, and we've done surveys and studies, that the elderly would actually prefer to die than have a stroke. So it's very, very significant. So where does this all come from? I mean, we can go back to Lancet in 2009, a very big study that was published from the ATT collaboration, and it looked at the use of ASA or aspirin in secondary prevention. And once again, we've described secondary prevention as having symptomatic or established coronary disease, stroke, TIA, or symptomatic peripheral arterial disease. And it showed that aspirin statistically significantly reduced the risk of another event by 19%. And that's where it's come from. So we're now looking 11 years ago. It's strongly been used across the world, and the evidence is there for its use. And I need to stress the bottom line here. So the bottom line is, we originally, as Ted mentioned, these were primary prevention guidelines, but we felt it was so important to reinforce what we already know, that for secondary prevention, ASA or aspirin is strongly recommended for patients with symptomatic coronary disease, peripheral arterial disease, or cerebrovascular disease. And just this morning, so I'm practicing virtual care, I had a phone call with a patient that was all upset that I told her to be on aspirin and have I read the new guidelines? So as I calmed her down, she'd actually had a history of a TIA, and she didn't realize, which is a very important fact, and I went through the guidelines with her, that really a TIA in this significance, in these guidelines, is secondary prevention. It's always secondary prevention. But so I think we're going to get calls like this. People may not understand that they actually have peripheral arterial disease because they don't equate their intermittent claudication or their TIA as being secondary prevention. But what we've done in these new guidelines has Ted has said, and Christine reinforced, that for primary prevention, when there is no symptomatic vascular event or confirmed vascular disease, we do not recommend the use of ASA. Oh, sorry, I was going to go back. Okay, so what do we do now for our patients? And I think that's the big question. In 2019, ACC AHA said to consider the use in patients aged 40 to 70 at higher risk of cardiovascular disease. That means a risk greater than 10%, but to avoid in those over age 70. Then we have our guidelines that have just come out yesterday, and we suggest that we don't use aspirin for primary prevention. Ted has shown you the recent trials and the meta-analyses that would agree, and hence we formed the basis for our guidelines based on those 3 trials and the 3 meta-analyses. But people are going to say we did see some benefit in the Zhang meta-analyses. We did see some benefit in Ascend with diabetics, and we'll address that in a second. But we need to understand that the increased risk of major bleeding, whether it be GI or intracranial, has been well established with ASA, as Ted is so has just shown us. And we saw similarly in the 3 large meta-analyses that this risk of major bleeding was increased. So there are conundrums, and I think exactly as the previous 2 speakers have said, we need to now sit down with our patients and have this discussion, because we don't answer all the questions. The evidence is not conclusive for or against aspirin with subclinical asymptomatic cardiovascular disease. For example, clinically insignificant coronary, peripheral, or carotid stenosis, lacunar infarcts. We just don't have the evidence. I think where family doctors are going to have the greatest discussion is in their diabetic patients, because we see in Ascend that there was a benefit of 12%, but we saw that there was a significantly increased risk of major bleeding. In fact, the number needed to treat was 90. The number needed to harm was similar at 111. So I think that's the type of patient we need to sit down with and discuss. Is it worth the risk to them? So the risk benefit here, looking at other risk factors. So are they a younger diabetic without any other risk factors? Are they an older diabetic that maybe has a family history, has high lipids, they smoke? So I think these are the discussions that family doctors are going to have. And I think Ascend is probably going to create the most controversy among primary care and pharmacists. So maybe we would consider ASA in our diabetic patients. I think for me, I'd have to weigh the pros and cons. And as I just mentioned, I would look at additional risk factors in addition to diabetes. But we have to use our judgment for other high-risk patients also where the evidence is lacking. And the current guidelines do not give guidance in this regard. But where they do give guidance is in the most common patients. So the 58-year-old that may have a family history, or the 58-year-old that has hypertension or hyperlipidemia. And I think was so well shown in the trials and the meta-analyses in Aspirin and Arrive that this would be a patient where we would recommend that they do not use aspirin. So maybe we need to stop ASA or have the discussion in our low-risk primary prevention patients. Maybe there's a lot of patients out there, and we know the numbers as we've seen that 2.5 million Canadians are taking ASA without their physicians knowing. And a lot of these are 45-year-old males who figure that they heard aspirin is good and they should be taking it. And I think we need to stress that aspirin is not like a vitamin. We shouldn't just be buying it. And that's where I think pharmacists can really help us now, educating our patients, helping educate our patients, doing medication reviews. But certainly, I would stop aspirin in my low-risk primary prevention patients if they're taking it, and I now need to ask them all. They don't have any diabetes or they don't have any subclinical atherosclerosis. Maybe it's that 58-year-old male or female with simply hypertension where I would stop aspirin, as we saw in Aspirin Arrive, or those with a high bleed risk. So I think our primary prevention guidelines will now apply to the majority of primary prevention patients. And yes, there's going to be controversies in those patients with subclinical atherosclerosis or diabetes. But for the majority of primary prevention patients, I think the evidence is clear that we probably should not be using aspirin. So now I'll hand it back to you, Patty, because we have lots of time for questions.
That's good. Thank you. And thank you all of our presenters for excellent presentations. We have quite a few questions, actually, so we will get right to them. I encourage everybody in the audience to send your questions in. So the first one I'm going to direct to Ted, to Dr. Wein. Here's the question. Would evidence on imaging of chronic microangiopathic ischemic change be sufficient to warrant the use of ASA? Would the clinical, without any clinical evidence of an event, would this tip somebody from primary to secondary?
So thank you very much for the question. It's an excellent question. I actually put that up on the slide. My last slide was of populations where we do not know what to do. That is a one of the areas that we have no guidelines to. So the two comments I will make is as follows. When we see small vessel disease on the brain, the number one causes of that are hypertension, diabetes, and it's usually a reflection of poor control of both of those. So to me, prior to asking whether aspirin would be a benefit is really to establish what the cause of the small vessel disease is. And so to ensure that these people's blood pressures are well controlled and to ensure that their blood sugars are well controlled. Other than that, we don't have any other evidence out there for prevention in this population, and I cannot give you a better answer than that. But I just want to remind you that aspirin is not the vitamin that prevents everything. And if we look at the benefits of lowering blood pressure by 10 millimeters of mercury, that carries a 30% relative risk reduction in subsequent vascular events. I think we should be focusing our energies on a lot of the standard preventative issues that are out there because the aspirin is a reactive measure and we really need to establish what the cause of that vascular disease is.
Thank you, Ted. Jeff, here's one for you. Is there an increased risk for acute coronary syndromes or stroke in patients that are currently taking ASA for primary prevention if you stop it?
You know, that's a great question, and we did discuss this, and Ted and Christine, you can correct me if I'm wrong. I think it's worth the discussion with the patient and seeing what other risk factors they have. But as I mentioned before, if I have a patient with a few risk factors, maybe they're a 55-year-old male, they're obese, and they have hypertension, as far as I know, there is no evidence for an increased event with discontinuing aspirin from these patients. And in fact, that's what I would do.
So I will just interject there. I think, you know, one aspect that we raised in all of our committee meetings is what happens to the individuals who are on an antiplatelet that we're going to take them off. And I think that leads to the question was, is there any rebound effect? And that we really don't know the answer. We do know that people who have symptomatic heart disease and stroke and are on aspirin for secondary prevention, that when these people have their antiplatelets stopped for a procedure, which we currently don't recommend be done anymore, that risk of stroke, that the risk of having an event in the symptomatic population, so secondary prevention, is around 2%. So I think the only concern one may have and one needs to think about, is there any rebound effect from all these people on primary prevention over the years who now can be taken off of it? Is there any negative sequelae to that? And that we don't know.
Thank you. Christine, this is one for you. I think you might be on mute, so if you can unmute. Is there any plan to create and display information about the appropriate use of ASA in the pharmacies or alongside where ASA is being sold? And would pharmacists ever consider putting ASA behind the counter?
That's an excellent question, and unfortunately I don't have an answer for that, but I think it's an excellent strategy to put forth. putting medications behind the counter is, it's a policy thing. It's something that I think that, it's something that we will probably take into consideration for sure, because of the potential risk and the fact that we're now in a situation where aspirin is just not simply, let's just pick it up off, outside the, off the counter outside the pharmacy counter. I don't know what certain pharmacies are going to be doing, big chain, the Shoppers Drug Mart, the Rexalls. I have no idea what their plans are, but I appreciate the question, because that is something that maybe I will take back to my colleagues and look and see how we can work with our organizations to see if this is something we should be doing. So thank you.
Thank you for that. And on the same vein, and maybe Christine, you can take the first comment at this, and then Jeff or Ted jump in. Should these recommendations be added to the Choosing Wisely list?
I think, again, that's Jeff, I'm going to leave that to you.
I would say not,
yes,
because I think Choosing Wisely looks more at investigations more than therapeutic interventions. So,
I don't know.
I don't know.
I'm
not sure.
Sorry. I would say I'm not sure either, but there are some Choosing Wisely recommendations with respect to the use of, certain medications in the elderly, for insomnia. So I think, it's something that could really be considered. And again, knowing some colleagues that are involved with that, to look to see whether or not they're even considering that. It would be something to be considered for sure.
Yeah, and I would still favor to include it, because I think there's a negative from this therapy to long-term exposure with the bleeding risk. And I think people need to be aware of that. And so for years, it's had a certain niche in our society. And I still think there's a niche for this drug. I just think it needs to be used wisely.
Yeah. And on that note, maybe we'll start this one with Ted. What if somebody's prescribed aspirin for another reason, and now we're telling them, but they also realize there is a benefit for their heart or preventing stroke? What do you say to them now, and how to, obviously we need to reassure them that if there's another reason, they should keep taking it. But what are your recommendations, maybe Ted and Jeff?
Yeah, so I guess I would comment, I'm not sure what the other reason you would be on aspirin for outside of pain control. I think if there's an indication for another illness or rheumatological condition, perhaps, that they may want to be using it, I think that's appropriate for that field. But I don't think there should be the misconception that this is having a significant impact on protecting your heart. And I think that's one of the reasons why people sort of automatically looked at this drug as like, oh, I'll try an aspirin. If it doesn't work for whatever else I'm taking it for, perhaps it'll have some cardioprotective effect. And I think that's the message we need to get away from. But again, I think in any particular situation, you need to discuss it with your healthcare provider who suggested it. You take it for this other condition to find out if it's absolutely necessary, where are the pros and cons of bleeding in that domain, but not to be misperceived that you're having cardiovascular protection.
I would agree with Ted. I was trying to think of other reasons apart from pain. 4 years ago, we took it out of the atrial fibrillation guidelines, and we said that the aspirin doesn't have a role in atrial fibrillation unless you're under the age of 65 with coronary disease, in which case it would be secondary prevention in any case. So I agree. I think you need to discuss it with the healthcare provider that's prescribed it, but I'm having trouble thinking of other indications other than the prevention of vascular disease and pain, in which case there are other drugs that we would probably use for pain that may be more efficacious.
And can I comment on that as well?
Yeah, please.
Okay, so I think, again, it goes back to that conversation with the patient. One, because, I'm in agreement with Ted and Jeff that there's no other perceived or evidence-based use for aspirin. However, patients may be using this, from a psychological, as they may choose to use natural products, right? So they may be saying, well, I have a history of colon cancer and I want to reduce my risk of colon cancer. Or for those people who can't take an anticoagulant for AFib, but want to take aspirin, so there's different reasons why they may be doing it. Again, their values and beliefs. So as long as they're informed of the potential harms, I agree, not suggesting that they're going to get any benefit for cardiovascular, but really delving into what is the reason that they want to use the aspirin, or what is the reason that their physician has given them for the aspirin.
So somebody has just added in a question saying that ophthalmologists will often use aspirin for retinal artery or vein occlusions.
I mean, I think that goes back to what we talked about before. I mean, those would argue that especially a retinal artery occlusion is symptomatic vascular disease, but we can have that debate, or is it, we can't really say it's asymptomatic cardiovascular disease. So I get that, and I've seen patients in that regard, and certainly that would not be a patient in my practice where I would stop aspirin.
And I totally support that. I mean, that's a vascular event that's occurred. You can't really say it's primary prevention at this point. It's really secondary prevention.
Okay, here's a doozy for you. What do you tell the 68-year-old patient with hypertension, obesity, very strong family history, and some coronary calcification found on abdominal CT with no prior heart or stroke event? Oh, and he's been on aspirin for 20 years.
I mean, I can address, I mean, that's a patient with multiple risk factors, and I will sit down with them now in light of this evidence and tell them what the guidelines are, but I will go over the trials and I will tell them that I don't know if there's a risk to them stopping, and I understand they have multiple risk factors. We don't know the significance of the calcifications, so maybe that is a significant factor, and as we mentioned before, we don't know. This would be worth a discussion with the patient, but I think most importantly now they need to be educated that this isn't as benign as they thought it was.
And I would add to Jeff's comment that, you know, this patient is almost the patient that would have been, for example, in the ARRIVE trial, a male over 55, 2 to 4 risk factors, with one of them being a positive family history and the hypertension. So the only question to me that separates this person a little bit is the coronary calcification. So as a neurologist, I'm not the world's expert on coronary calcifications, but I'm really not sure what to make of that. And I'm not sure I would really include that as vascular disease. If you go back of vascular disease responding to antiplatelet therapy, I'm just going to go back to our initial recommendation in the guideline, which was on the first point that said, and Patty, if you want to put up slide 12, it's the last point there, but it says the net benefit of aspirin in individuals with asymptomatic atherosclerosis is uncertain. Level of evidence B. And we gave it a level of evidence B because the only trial we could find or study that we could find out there was a study that was looking at individuals with asymptomatic carotid arteries stenosis from the ACAS trial. And in this study where Robert Cote, my colleague at McGill, is the author, when they looked at subsequent events on the aspirin arm versus the non-aspirin arm, there was no benefit that it actually decreased any cardiovascular event in that cohort of people. So we really don't know what to do when you start seeing this. But as Jeff said, it will file more into primary prevention, and it would be a sit-down talk with your patient.
And then final
based
question,
on that point alone.
Thank you so much. Final question then is to Christine. Christine,
Yep.
should the same guidelines apply to people taking natural forms of aspirin like willow bark?
Absolutely. I mean, I would say absolutely, because first of all, when it comes to willow bark, we don't even know how much they're actually taking. The restrictions are in terms of what is contained. What am I looking for? What's the word I'm looking for? Health Canada's ability to ensure the production of natural products is not the same as other medications. So with the willow bark, we don't even know what percentage. They may be taking even more than 100 milligrams, which then you could argue the risk is going to be greater. So I would say yes. I would use the same approach in terms of decision making, and I would actually emphasize that if they really wanted to use aspirin based on their values and preferences, that they actually use baby aspirin and not willow bark.
Great, thank you for that. Any final comments from any of our three presenters?
No.
I mean, I'll just comment from primary care. I think we're probably gonna need to change what we do in terms of asking patients if they're taking aspirin, because obviously, unknowingly, a lot of them are. And I think it's worth a discussion on, here are the new guidelines. Do we really believe you're going to derive benefit from taking aspirin? And you have to understand there are risks. So it's not a reflex approach, everyone on or off aspirin. I think it's worth the discussion, citing the evidence. It's going to be a lot easier for those patients going forward that aren't taking it and are asking you. We can give them a much more definitive answer. But for those 2.5 million Canadians already on aspirin without us knowing, that's going to have to be discussed.
And I think my message to everyone is just to readdress these issues when patients come to see you and are on aspirin, is to make sure they're on it appropriately. And it warrants a discussion. I don't think it's one of those things that you just record the medication list for your patients and then go on. But I think everybody should be questioned as to why they're taking it. Have a discussion with them to make sure that it's the optimal therapy for your patients.
And can I just make a comment? I think now too that most clinics, and not all clinics, but there's even those clinics that have EMRs and have tablets available and can actually ask that question. You can actually do a very small scale quality improvement type of approach to ask patients. Not only are they, we ask often now, are they smokers? Are they considering stopping? But you can say, are you taking aspirin? Would you like to have a conversation about this? Please have a conversation if yes, right? So there's ways that we can actually trigger that in our patients, even at the reception desk.
Thank you all so much. That was fantastic. We had a huge audience that stayed on the entire time, so you've captivated many people. For all those listening, thank you very much for your time today among all the other things you're dealing with. When your practice and your time allows, please help spread the information about these guidelines and the need to start having those conversations. We do have some patient flyers that we've created that will help you with those conversations. You can download them from our website free, and you can post them up in your offices. So thank you again to everybody. We wish everybody to be well and safe. And for those health providers that are working on the front line, thank you. Thank you for everything that you're doing. Heart and Stroke has put out information on our website about COVID and our diseases. We're trying to keep up to date, so please share that information with your patients if they're looking for specifics. We're doing a bit of with that, working with our colleagues. So thank you all, and please join us in a month's time when we're going to do a webinar on sleep health and cardiovascular disease.
Thank you very much.
Thank you, everyone. Thank you. Be safe.